So I would look at this in two ways. Where do we go next with this research, and then how does this now, today, even without research, impact clinical care? Just talk about the first. For research, there's a lot more we need to know. I want to know more about predictors of response. So there are certain subpopulations that may be more likely or not likely to respond, with or without, say, other psychiatric symptoms like psychosis or physical aggression or depression. There may be groups that are less likely to respond that you would want to avoid, and maybe there are groups that are more likely to have side effects that you'd want to avoid. To do that, we can do some post hoc analyses on our data. This was the first pass primary outcomes that we're presenting now at this meeting. But I think it would require larger studies. The other future direction is the relationship of these treatment effects with biomarker changes. So we do have data that we collected on neurofilament light, on p-tau217, on A-beta 42 and 40 in the serum. So we're going to have some ability to look at biomarkers that may predict response. We also have data on neuroinflammatory markers, really serum, blood-based neuroinflammatory markers, cytokine data, which we will also look at, because one of the putative effects of cannabinoids is on reducing neuroinflammation, and another is a direct effect on the CB1 and 2 receptors. So those are potential studies that we can do with our current data set. Future research in this area, I think, has to somehow take into account that most people, and I'm speaking in the United States here, most people in the United States are in states where medical marijuana or dispensary marijuana is available. And so family members are getting this for their loved ones, who are their grandparents, their parents, their spouses who have dementia, to help them sleep, to reduce their pain, to reduce anxiety. And when you buy the stuff over the counter in a dispensary, you have no idea what's in there. You don't know what the other types of cannabinoids that are in there, THC, CBD ratios, drug interaction issues. None of this has been studied terribly well at all. And so when my patients and their families come to me and ask me for guidance on what to take, I don't know how to answer the question because I have no data to go by. This is a drug that's been formulated in a synthetic preparation. It's been on the market for 40 years. We know a ton about its pharmacokinetics and dynamics. You can't translate that directly to what to say to do, in buying something over the counter in a dispensary. So I think and could we study that? Right now the regulatory situation in the United States is such that it would be very hard to study dispensary level cannabinoids without substantial, regulatory oversight. So I think there are some barriers that are going to make it hard to study anything but either CBD or potentially other synthetic THC products. In terms of clinical practice now, so right now, the most recent practice guidelines on the treatment of psychosis in Alzheimer's disease, not even agitation, came out 8 years ago from the American Psychiatric Association. So we need to update our guidelines, and there are a few things that need to be updated. One is we have to double down and re-emphasize the importance of the full assessment of the patient, because agitation is a symptom. It's a syndrome. It says nothing about etiology. It could be the disease itself. It could be the time of day. It could be the way your loved one talked to you in the morning. It could be somebody helping you bathe. And that's why this is so hard to treat, is because the etiology is so different. So I think we have to come up with better tools that include digital biomarkers so that we can track people over time and really have a better objective measure of agitation than these interviews we currently conduct with patients and their families to get scores on a rating scale. So I think that's a huge area of research, but it's a really clinical important need. It's like collecting data on these symptoms is really hard. We have to really advance that. And we have to do a better job of understanding etiology. Once we have a better understanding of etiology, then we can target therapies. So for example, if this is an agitation syndrome that's not just caused by an external event in the environment, it's persistent, it's severe, and it's causing an impact on quality of life for the patient and their loved one, and they don't have psychosis and they don't have depression, that's where the cannabinoids may fit in. Agitation without psychosis or depression. If you have agitation with psychosis, I'd be anxious about that, because these drugs can actually cause delusions or hallucinations, theoretically at higher doses. It's cannabinoid after all. So we have to be cautious about the kind of subpopulation that we're treating with cannabinoids, and I would stay away from people who have dementia with psychosis, for example. But I think we have to do more research to really figure out where these drugs will fit in. For now, though, if I have a patient who's got agitation, wandering, pacing, restless, it's not provoked by the environment only, it's not occurring in the setting of delirium, the person's not depressed and they're not psychotic, but they've got Alzheimer's disease, I think that's a role for the cannabinoids and for synthetic THC.